Welcome back to the deep dive. Today, we are attempting something, well, something truly ambitious, a mental tour of the wrist and the hand,
And we're pulling this exclusively from a single chapter in Gray's Anatomy.
which is just an immense challenge. I mean, normally to study this region, you'd want a diagram right in front of you or, a cadaver.
Exactly. The hand is just this anatomical masterpiece. You can do everything from a 100-pound crushing grip to threading a tiny needle.
And our mission here is to help you, the listener, mentally visualize this whole three-dimensional structure, all the tiny bones, the ligaments, the tunnels.
All of it. Just through descriptive language, we're going to try and turn those dense diagrams into dialogue.
So where do we begin?
We have to start right on the surface. The foundation of the hand's function, its precision, its mobility, its power, it all rests on this incredibly complex space. So let's break it down layer by layer.
Okay, let's unpack this, starting with the surface. If you flex your wrist, you can see those skin creases on the front. There are usually 3 of them.
Right. And there are so much more than just wrinkles. They're like topographical guides. That first one, the proximal line, that tells you where the flexor synovial sheaths begin.
Okay. And the one in the middle.
That's a key one. The intermediate line overlies the radiocarpal joint itself, and the distal line, the last one, marks the top border of that crucial flexor retinaculum.
Which is the roof of the carpal tunnel. We'll definitely get to that.
We will.
Yeah.
And even in the palm, those creases, like the one that circles the base of your thumb.
The radial longitudinal line.
Exactly. It perfectly outlines the muscle bulk of the thumb, the thenar eminence. These creases are anchored tightly to the deep fascia. They're not random.
Why is that anchoring so important?
It stops the skin from sliding around or tearing when you grip something. It's a brilliant piece of engineering. And that brings us to the blood supply.
Okay.
If you look at your fingertips, the arteries that supply the pulp of the finger, the palmar digital arteries, they form this very specific connection. It's an H-shaped anastomosis.
An H.
Yeah, a unique H-shaped loop in the distal phalanx. It's a protected network, basically, designed for all the impact and sensation that happens at our fingertips.
What's really fascinating, though, is the venous drainage. It seems counterintuitive.
It does. Even though the arteries run down the front, most of the superficial venous return actually gets routed to the back of the hand.
So the veins on the back of your hand are doing most of the work.
That's right. The superficial palmar veins drain dorsally into that much larger dorsal venous system. It's a functional thing. If your hand swells, the back of your hand is where you'll see most of that fluid.
All right, let's talk sensation. The nerve territories. If you were drawing a map on your hand, where do the 3 big nerves land?
The 3 main players are the median, ulnar, and radial nerves. Very specific territories. The median nerve takes care of the palmar skin of the radial 3.5 digits.
So thumb, index, middle, and half of the ring finger.
Exactly. Then the ulnar nerve gets the other side of the palm, the little finger, and the other half of the ring finger, so it's a clean split on the palm.
But not on the back.
No, the map flips. The radial nerve supplies the dorsal skin of those same 3.5 digits. But there's a catch.
Okay.
It only goes as far down as about the middle knuckle, the proximal interphalangeal joint.
So the back of your fingertips aren't supplied by the radial nerve.
Whoa, and this is the detail that frequently trips people up. The dorsal skin of your fingertips is actually supplied by tiny little branches from the palmar digital nerves.
So from the median and ulnar nerves looping around.
Precisely.
Yeah.
So even on the back, the sensory map is more complex than you'd think.
Okay, moving deeper. We get to the structures that sort of channel and compartmentalize everything. The retaining walls of the wrist. The retinacula.
And the most famous, of course, is the flexor retinaculum. The best way to picture it is like a strong, broad band of duct tape stretching across the arch of your carpal bones.
Where does it attach?
It attaches medially to the pisiform and the hook of the hamate, and then laterally to the scaphoid and trapezium. And by bridging that bony groove, it turns it into the carpal tunnel.
And inside that tunnel is all the critical cargo. The flexor tendons and, of course, the median nerve.
Right. But there's another tunnel right next door, a smaller one called Guyon's Canal.
Okay, what's the key difference with Guyon's canal, besides just being smaller?
Well, it transmits the ulnar nerve and ulnar artery. But what's clinically crucial is where that ulnar nerve splits. It usually divides into its deep motor branch and its superficial sensory branch inside the canal.
And why does that matter?
It means that if you get compression just at the end of the canal, you might only lose motor function. Your palm sensation could be totally fine. It helps you pinpoint the problem.
Got it. And on the other side of the wrist, the back, we have the extensor retinaculum.
Yeah, and its job is to stop the extensor tendons from flying up like a bowstring when you straighten your fingers.
It holds them down.
It holds them down. It anchors to the back of the radius with these little vertical ridges, and it creates 6 separate, snug compartments for the tendons.
I remember reading about compartment 6 as being special.
It is. It just houses one tendon, the extensor carpi ulnaris, and its sheath is kept separate for a very good reason.
Which is?
It has to be able to move independently to allow you to rotate your forearm. If it were locked in with the others, that supination and pronation would be compromised.
Okay, let's shift into the palm itself, the palmar fascia. This isn't just some simple sheet, is it?
No, not at all. Grace describes it as a true three-dimensional ligamentous system. It's this intricate web of longitudinal, transverse, and vertical fibers. An architectural marvel, really.
And the most important part.
The thickest part, the longitudinal fibers. They make up the palmar aponeurosis, and they are critical because they anchor the skin distally.
So why is anchoring the skin so important functionally?
It resists horizontal shearing forces. I mean, think about holding a hammer or a climbing rope. If your skin could just slide around independently of your muscles, you'd have no grip. These fibers lock it down.
And what about the ligaments in the fingers, clelands and Graysons?
They're there to stabilize the neurovascular bundles. Clelands are thick and run dorsal to the bundles. Graysons are much more delicate and run on the palmar side.
And this whole system is what goes wrong in Dupuytren's disease.
Exactly. The normal fascial bands get replaced by these hard pathological cords, and they pull the fingers down into flexion.
And that creates a problem for surgeons.
A huge problem. These cords, especially what we call the spiral cords, can actually displace the neurovascular bundle, pulling the nerve and artery into a really vulnerable position. A surgeon has to know that anatomy cold to avoid cutting them.
Wow. Okay, let's get to the bones, the skeletal foundation.
Right. If we strip away the fascia, what's so fascinating is the stability that comes from the wrist's bony core, the carpus. It's an intricate puzzle, 8 small bones in 2 rows.
The proximal row, closest to the arm, is the scaphoid, lunate, triquetrum, and pisiform.
And the distal row connecting to the hand is the trapezium, trapezoid, capitate, and hamate. And you don't need an x-ray to find some of them.
You can feel them.
Oh, yeah. You can easily feel the pisiform on the medial ulnar side of your wrist. And if you go about 2.5 centimeters down and 1 centimeter over from there, you can feel the little bump of the hook, the hamate.
Clinically, though, we have to talk about the scaphoid. It's the most fractured carpal bone, and it's famous for not healing well. Why is that?
It's a classic case of anatomical vulnerability. The scaphoid is almost entirely covered by articular cartilage.
Which doesn't have its own blood supply.
Exactly. So there's very little surface area for arteries to get into the bone in the first place. If you fracture it through the middle, through its waist, you often sever the internal blood flow.
So you're cutting off the power supply to 1/2 of the bone.
That's a perfect analogy. The proximal fragment is left without blood.
Yeah.
And that avascular necrosis means non-union is a huge risk.
We should also quickly mention the lunate.
Yes, it's known for its deep socket that fits the capitate, but it's also susceptible to something called Kienböck's disease, which is a similar kind of osteonecrosis. It just highlights how fragile the blood supply to these little bones is.
And finally, the metacarpals. The thing that really defines the human hand is the first one, right? The thumb.
Absolutely. The first metacarpal is shorter, thicker, and this is the key. It's rotated medially by a full 90 degrees on its axis compared to the others.
And that rotation is what lets us...
Suppose the thumb. It allows the thumb to flex across the palm to meet the fingers. That's the mechanical key to all our dexterity.
Okay, now for the mechanics. How does this whole bony puzzle actually move? The main joint is the radiocarpal joint.
Right, where the radius articulates with that proximal carpal row, the scaphoid, lunate, and triquetrum. But the wrist relies on this incredibly complex web of ligaments for support.
We split them into extrinsic and intrinsic ligaments.
We do. Extrinsic connect the carpus to the forearm. Intrinsic connect the carpal bones to each other. And they form these powerful stability units, like the V-shaped arcuate ligament on the palmar side.
But even with that strong ligament, there's a known weak spot in the architecture.
Yes, the space of Poirier. It's this little interval, this gap near the lunate, that often doesn't have many stabilizing fibers.
And that's where dislocations happen.
It's the most common route for a traumatic lunate dislocation. It just shows that precarious balance between mobility and stability in the wrist.
Let's talk range of motion. We get a lot of flexion and extension, about 85 degrees each, but side-to-side movement is really asymmetrical.
Very. You get about 45 degrees of ulnar deviation or adduction, but only about 20 degrees of radial deviation or abduction.
And that movement is shared between joints. It's not all happening in one place.
That's the key insight. Adduction happens mostly at the radiocarpal joint.
Oh.
You can actually feel the triquetrum bone bumping up against the cartilage disc. But abduction relies heavily on movement at the midcarpal joint, between the two rows of carpal bones. It's a controlled slide.
Okay, moving out to the digits. Let's clarify the rules for the knuckles, the MCP joints versus the finger joints, the IP joints.
This is a really crucial distinction. At your knuckles, the MCP joints, the collateral ligaments, are tight when you make a fist.
Meaning you can't wiggle your fingers side to side.
Right. But when your fingers are straight, the ligaments are lax, and that allows you to spread your fingers wide.
And that flexibility is gone at the IP joints.
Correct. At the proximal and distal IP joints, the collateral ligaments are designed to be taut through the entire range of motion, flexion, and extension. They only allow bending and straightening. No side-to-side wobble. It's all about stability for grip.
And there's a structure that links these two joints, the oblique retinacular ligament of Landsmeer, the ORL. How do we visualize that?
Think of it like a passive string. When the middle joint, the PIP joint, straightens, the ORL pulls taut, and it passively pulls the fingertip, the DIP joint, into extension too.
A tenodesis effect.
Exactly. It's a neat little mechanism that coordinates the movement of the two joints.
So we have all these bones and joints, but how does the fine motor control actually happen?
That's the million-dollar question. It's all down to this complex interplay between the long tendons coming from the forearm and the small intrinsic muscles inside the hand itself.
Let's start on the palm side with the flexor tendons. They're held down by a pretty sophisticated pulley system.
They are. These fibrous flexor sheaths have what we call A for annular and C for cruciate pulleys. Think of a fishing rod. The pulleys are the guides that keep the fishing line, the tendon from lifting off the rod when you're pulling hard.
And some are more important than others.
Oh, absolutely. Surgically, the A2 and A4 pulleys are the most critical. If you rupture those, the tendon will bowstring away from the bone, and you lose a massive amount of grip strength.
On the back of the hand, the extensor tendons spread out over the knuckles, the extensor expansion.
Right, it's this triangular fibrous hood. When the long extensor tendon gets to the knuckle, it splits into three parts.
Trifurcates.
A central slip attaches to the middle phalanx to straighten that middle joint, and then two lateral bands continue on down to the fingertip to straighten the end joint. It's a very elegant, multi-level control system.
But you said the real genius is in the small intrinsic muscles, specifically the lumbricals.
They are the key to a smooth, coordinated grip. They're unique because they actually start on the mobile tendons of the big flexor muscle, the flexor digitorum profundus, and they insert into that extensor expansion on the back.
That's a strange arrangement. So what does that do functionally?
Their job is to start the motion of bending your knuckles, your MCP joints, while at the same time stopping your fingertips from curling up too quickly.
So they sort of orchestrate the grip?
They orchestrate the arc of your grip. If you go to pick up a coin with a precision pinch, the lumbricals are what allow your fingers to form a smooth, curved hemisphere for a perfect pulp-to-pulp pinch, instead of just hooking your tips right away.
Okay, let's take all of this incredible architecture and apply it to some clinical problems. Nerve compression syndromes. Back to the median nerve in the carpal tunnel.
Right, carpal tunnel syndrome is compression of that nerve under the flexor retinaculum. Motor-wise, you lose the first two lumbricals, and crucially, those thenar muscles that move your thumb.
And what's the anatomical clue that tells you the problem is right there at the wrist and not higher up the arm?
It's the location of a specific sensory branch. The palmar cutaneous branch of the median nerve, which gives sensation to the base of your palm, usually comes off before the nerve even enters the tunnel.
So in carpal tunnel syndrome, that patch of skin on your palm should still have normal feeling.
Exactly. Sensation there is spared. If that sensation is gone, the problem is probably higher up in the forearm.
Okay, now let's contrast that with ulnar nerve entrapment in Guyon's canal.
Similar story, different nerve.
Yeah.
Compression there leads to paralysis of almost all the other intrinsic muscles. The interosseous, the hypophenar muscles. It causes finger clawing and a very weak pinch.
Can we use the sensory map again for localization?
We do. The dorsal cutaneous branch of the ulnar nerve, the one that supplies the back of the ulnar side of your hand, branches off about 5 centimeters before the wrist.
So it's well clear of Guyon's canal.
Way clear. Yeah. So, sensation on the back of your hand is spared in Guyon's canal compression. Again, it tells the clinician the problem is localized right there.
And one final clinical point, ligament stability in the thumb, the Stanner lesion.
This is a classic ski pole injury.
Yeah.
You tear the ulnar collateral ligament of the thumb's MCP joint. But the critical problem isn't just the tear.
What happens?
The torn end of the ligament gets displaced, and it gets trapped on top of a nearby muscle aponeurosis. That soft tissue gets in the way and physically prevents the ligament from healing on its own. It requires surgery. It's a perfect example of how unforgiving hand anatomy can be. So we've taken this deep dive into the hand. We've tracked the dual roles of fascia, which both anchors skin and creates these vital tunnels. We've seen the inherent instability of that proximal carpal row, which needs complex ligaments to control it. And maybe most importantly, we broke down the precise muscle coordination led by that unique action of the lumbricals that allows for our grip.
It's just an astounding level of functional engineering in such a small space. Thank you for joining us on this deep dive.
And as you reflect on the continuous complex movements of your hands today, consider this. Peripheral nerves, like the median and ulnar, are not just static wires. They're living tissues designed to glide and stretch. Studies have shown they can move up to 15 millimeters longitudinally at the wrist during normal movement. This incredible physical adaptability is essential for avoiding injury during continuous motion. It's an anatomical necessity we take completely for granted until that mobility is lost. That adaptability is, in a way, the hand's final protective layer.